Dr. Clark, are you ready?
I am.
Very good. Thank you all. So we'll resume with a presentation by Dr. Clark on an update on COVID-19 vaccines and anaphylaxis. Dr. Clark, please go forward.
Good afternoon. Thank you. Next slide. On December 8th, 2020, the United Kingdom initiated its vaccination program with the Pfizer-BioNTech COVID-19 vaccine. The following day, December 9th, UK authorities confirmed 2 cases of anaphylaxis after vaccination. As with other vaccines, prescribing information for both Pfizer-BioNTech and Moderna COVID-19 vaccines contains information on anaphylaxis, namely that severe allergic reaction or anaphylaxis to any component of the vaccine is a contraindication to vaccination, and that appropriate medical treatment to manage anaphylaxis be immediately available and used in the event of anaphylaxis. Next slide. ACIP considered this prescribing information and the UK reports of anaphylaxis in its deliberations at the December 11 and 12 meeting, and on December 12, published clinical considerations that included guidance on anaphylaxis as a contraindication. Next slide. As of December 18th, 2020, CDC has identified 6 case reports of anaphylaxis following Pfizer-BioNTech vaccine and meeting Brighton collaboration criteria for anaphylaxis. These cases met Brighton collaboration levels 1 or 2. Additional case reports have been reviewed and determined not anaphylaxis. These cases occurred within the recommended observation window post-vaccination and were promptly treated. Investigations are ongoing. However, we do know that 1 case had a history of anaphylaxis following rabies vaccination. All suspect cases were notified through VAERS or other CDC notification processes, and in most cases through multiple channels. These case reports are undergoing or will undergo clinical case review by our clinical immunization safety assessment project. As of December 19th, 272,001 doses of vaccine have been reported as administered. I do encourage you to interpret this number with caution, though, as it's probably a minimal estimate. Providers are requested to report administration within 72 hours to jurisdictions and jurisdictions within 24 hours to CDC. Next slide. Since notification of these cases and during our investigations, CDC has been in close coordination with FDA. We've held discussions with CISA investigators, NIH, the Medicine and Healthcare Products Regulatory Agency of the UK, allergy and immunology experts, and other partners. And on December 16th, we published interim considerations on preparation for the potential management of anaphylaxis at COVID-19 vaccination sites. Next slide. I'd also like to update on our vSafe active surveillance project. So as of December 18th, yesterday evening, 112,807 people had registered and reported receipt of 1 dose of vaccine. 3,150 of those people reported an adverse event that had an impact on their health, either limitation of performance of normal daily activities or going to work, or for which they sought medical attention. 514 recipients reported pregnancy. CDC has mechanisms in place to follow up medically attended reported AEs and extensive follow-up of vaccinated pregnant women. Next slide, please. So to summarize our post-authorization pharmacovigilance systems have detected and confirmed 6 anaphylaxis cases following vaccination. These notifications have been received in a timely fashion, mostly within just a few hours. And several notifications have been ruled out, indicating that our systems are sensitive to identify anaphylaxis. We will continue to reinforce measures to recognize, respond, and report anaphylaxis. In the subsequent presentation by Dr. Mbei, we'll review in detail our CDC guidance on anaphylaxis. Persons with anaphylaxis following COVID-19 vaccination should not receive additional doses of COVID-19 vaccine. We're also working in consultation with allergy and immunology experts to provide further guidance on the evaluation of persons who have had anaphylaxis following COVID-19 vaccination. Next slide, please. I'd really like to thank FDA and our other partners, including Pfizer, and especially acknowledge the CDC Immunization Safety Office staff who've been so diligent and timely in following up on these cases. And that concludes the presentation.
Thank you very much, Dr. Clark, for that information that we were all looking for and needed.
Dr. Romero,
Are there any questions?
yeah, let's
Yes,
take some quick questions on this presentation. We do have a follow-up presentation on this as well, but let's take some direct questions on this one.
Yes, I was about to ask for. Ms. Bata.
Yes, thank you, Dr. Romero. And the question I have is related to the V-safe surveillance. Have you been following up with those individuals that have been reporting health impact events? And if so, what are you learning from them?
We are following up on those. The number has been sort of quite substantial, so we're focusing on those with medically attended adverse events, as those are of the most interest. And I don't think we have anything systematically to share yet in terms of results.
Dr. Bernstein.
Thank you. Yes, I was wondering along those lines, so you are able to separate out those that required medical care versus those that are just impacting daily activities or ability to go to work?
Yes.
Thank you. I think that's quite important. Thanks.
Thank you. Dr. Bell.
Thank you. I just thought I would ask a few of the obvious questions about the anaphylaxis case. I recognize you may not be able to answer them, but to the extent that you can, I'm curious about whether there's any clustering, especially geographically speaking, among these cases, and any other aspects of the cases that they share, so that we, begin to get a bit of a sense of what kinds of things might explain this sort of phenomenon.
Thanks for the question. I think it's early days to share yet. Investigations are ongoing. I will say that persons with anaphylaxis have received vaccine from more than one production lot. Multiple lots have been distributed and are being used. But probably not equally. You folks may have seen in the news a couple of cases from Alaska, but we've had reports from other jurisdictions, so there's no obvious clustering geographically.
Thank you.
Are there any other questions? Dr. Atmar.
Yeah, thank you. So can you give us an idea, or maybe I missed it if you said it, how many of the health impact events were actually medically attended events?
Or
what percentage? Or
I don't have the exact number with me, but it is the minority of the 3,150 that either were medically attended or affected going to work or performing daily activities.
And are we going? When do you think we'll get a more detailed sort of report to us or to the public?
We're working diligently to summarize our data and put it out as quickly as possible. So as soon as we have something informative, I'd say it's a bit of a fuzzy answer, but as soon as we can.
Thank you.
Thank you. Dr. Paling.
Yes, Dr. Clark, thank you for this presentation. I wanted to ask about the 6 cases with anaphylaxis. How many of them were hospitalized? I believe you said one had a history of anaphylaxis to rabies. Were there any others with a history of anaphylaxis to other things?
No others had confirmed anaphylaxis with other medications or foods or other exposures, though investigations are ongoing. I believe most were hospitalized and treated and observed. I think that's. We're careful not to sort of really describe individual cases. But.
Okay, thank you. That's very helpful. I appreciate it.
And most vaccination is going on, still in hospital settings, so they're often being vaccinated in the places they work.
Let me ask, Dr. Clark, let me ask a follow-up question to that. Is there a way that without just divulging anything that can't be, give us some information on the ages of the individuals?
Sure. All have been adults and are under the age of 65.
Thank you. Dr. Lee.
Thank you so much. I just wanted to perhaps comment that number one, I really appreciate that the systems that are in place are both sensitive and timely. It's really only the first week of the vaccination program, and already you're bringing information to the group, and so I really appreciate that. The second is, I recognize we still have more work to do in terms of really estimating and understanding the risk, but to me it does seem qualitatively higher than for most typical vaccines. But just to state out loud that for me personally, it doesn't necessarily change the benefit-risk balance of the COVID-19 vaccines at this time. I think it's really important for us to rapidly understand and manage all of the risks that come with vaccination and still make sure that we're providing access to the vaccine to the population. So again, I think this is, we'll learn more as we go and we'll adapt any recommendations or clinical guidance as needed. But just wanted to reiterate that this is exactly what's supposed to happen in terms of vaccine safety surveillance and making sure that ACIP and the public are aware that that all of this is continuing to be under investigation and being done in real time. So thank you.
Thank you.
Dr. Kimberlin, please go forward.
Yes, David Kimberlin, AAP Redbook. I apologize if y'all have already addressed this. I'm traveling across Interstate 20 across multiple states and might have missed it. Per the reports in the newspapers, several of these cases of anaphylaxis have occurred at the same hospital. In other words, one hospital would have 2 cases. Presumably, then many other hospitals would not have any cases. Is that unusual?
I mean, it is early days, and I think people are sensitive to this potential risk associated with vaccination. Investigation doesn't always confirm multiple cases at the same facility, and we have certainly heard of some cases that have been ruled out at the same facility. So true clustering of anaphylaxis would be concerning, but is very unlikely. And there's no indication we're seeing clustering here, even if there are 2 cases.
Thank you. Ms. McNally.
Thank you, Dr. Clark. I'm the consumer representative, and I'm just wanting to talk briefly about vSafe. Since it was a new system, can you just discuss whether it is performing the way that you anticipated it would perform and whether any updates are needed?
Sure. I think, I'm not sure how everyone anticipated it would perform, but I think we have been very pleased with how it is performing. Both the number of persons enrolled and the events being reported are what we hoped would be reported. I did a little sort of quick calculation, and that the number of enrollees was something like 2/3 of the number of doses administered around the same time. So uptake seems good. There have been minor tweaks, I think, to the system, but overall it's performing well, and does allow us to trigger sort of further investigation both within the system and with in-person phone follow-up.
Thank you.
Thank you. So we will move on now to the next presentation, which will be Dr. Mumbai's presentation on clinical considerations for the use of mRNA COVID-19 vaccines. Please go forward, Dr. Mumbai.
Thank you very much. Good afternoon. Today I will be reviewing clinical considerations for the use of mRNA COVID-19 vaccines in the United States. Next slide. Clinical considerations for the use of Pfizer-BioNTech COVID-19 vaccine were presented to ACIP on December 12th, and the final considerations were published to the CDC website. These clinical considerations will be updated to include information on both authorized mRNA vaccine products, Pfizer-BioNTech and Moderna COVID-19 vaccines. The guidance has been harmonized across products with few differences, including differing age indications and dosing schedules. In this presentation, I will focus on considerations around contraindications and precautions to vaccination. Next slide. Next slide. For both of the currently authorized mRNA COVID-19 vaccines, severe allergic reactions, such as anaphylaxis, to any component of the vaccine is a contraindication to vaccination listed in the prescribing information. The prescribing information also stipulates that appropriate medical treatment used to manage immediate allergic reactions must be immediately available in the event that an acute anaphylactic reaction occurs following administration of the vaccine. Next slide. This table shows the ingredients included in the mRNA vaccines as reported in the prescribing information. Both vaccines consist of nucleoside-modified mRNA encoding the viral spike glycoprotein of SARS-CoV-2. In addition, both contain 4 different lipids, some of which are common between the 2 vaccines, as well as salts, sugars, and buffering agents. Neither vaccine contains preservatives, and the vial stoppers do not contain natural rubber latex. Next slide. I wanted to highlight that polyethylene glycol, or PEG, is a component of both vaccines. PEG is a primary ingredient in osmotic laxatives and oral bowel preparations for colonoscopy procedures, an inactive ingredient or excipient in additional medications, and is used in a process called pegylation to improve the therapeutic activity of some medications, including certain chemotherapeutics. Next slide. While the reports of anaphylaxis in persons who received the Pfizer-BioNTech COVID-19 vaccine are further investigated, CDC considers a history of severe allergic reaction, such as anaphylaxis, to any other vaccine or injectable therapy, including intramuscular, intravenous, or subcutaneous preparations, as a precaution but not contraindication to vaccination in both the Pfizer-BioNTech and Moderna COVID-19 vaccines, as these vaccines contain some ingredients in common. A risk assessment should be conducted in persons who report a history of severe allergic reaction, such as whether the reaction required use of epinephrine or resulted in hospitalization. These persons may still receive vaccination, but they should be counseled about the unknown risks of developing a severe allergic reaction and balance these risks against the benefits of vaccination. Next slide. Persons with a history of other types of allergies do not have a contraindication or precaution to vaccination, such as those with history of food, pet, insect, venom, environmental, latex, or other allergies not related to vaccines or injectable therapies. History of allergy to oral medications, including the oral equivalent of an injectable medication. No serious allergy or a non-serious allergy to vaccines or other injectables, as in they didn't have anaphylaxis or any other serious complications. Family history of anaphylaxis, but no personal history or any other history of anaphylaxis that is not related to a vaccine or injectable therapy. Next slide. CDC recommends that vaccine providers observe all persons after vaccination. Those with a history of anaphylaxis due to any cause should be observed for 30 minutes. All other persons should be observed for at least 15 minutes after vaccination to monitor for the occurrence of immediate adverse reactions. Next slide. This figure is included in the clinical considerations document and is intended to assist vaccination providers better determine which patients may proceed with vaccination, which have precautions to vaccination, and which have contraindications to vaccination. It includes information on how to approach patients with medical conditions, as well as a history of allergic reactions, which is in the bottom row. In green are those patients with a history of allergies in whom there is no precaution or contraindication to vaccination. As mentioned on the last slide, those with a history of anaphylaxis should be observed for 30 minutes, whereas all other persons should be observed for at least 15 minutes. In the next column in yellow are those persons with a history of anaphylaxis to another vaccine or injectable therapy. A risk assessment should be conducted in these patients, and if vaccinated, they should be observed for 30 minutes. In red are those patients with a history of severe allergic reaction to any component of the Pfizer, BioNTech, or Moderna COVID-19 vaccines. These people should not be vaccinated. Next slide. In addition, CDC has developed tools that providers can use at the vaccination site to help identify persons with contraindications or precautions to vaccination, including a pre-vaccination form and further additional information in a fact sheet. Next slide. CDC has also developed interim considerations for preparing for the potential management of anaphylaxis at COVID-19 vaccination sites. These considerations include information on early recognition of anaphylaxis, medications and supplies needed for the assessment and management of anaphylaxis, how to manage anaphylaxis at the vaccination site, patient counseling, and reporting of anaphylaxis. Fact sheets are under development, including one tailored to long-term care facilities, given some unique challenges that may be encountered, such as recognizing anaphylaxis in persons with impaired cognition or who can't communicate symptoms following vaccination. Next slide. The key take-home messages from our anaphylaxis guidance include the importance of early recognition of anaphylaxis symptoms, prompt treatment with epinephrine, and immediate activation of emergency medical services. Next slide. COVID-19 vaccines will likely be administered in a wide variety of clinical settings, including hospitals, long-term care facilities, outpatient medical offices, pharmacies, mass vaccination sites, and curbside or drive-through sites. These settings differ in terms of usual on-hand human and material resources to manage anaphylaxis. In our guidance, we've included a list of medications and supplies that are important for evaluating and managing anaphylaxis and are recommended for COVID-19 vaccination sites. We've divided them into supplies and medications that should be available at all sites as the minimum requirements to assess and manage anaphylaxis, as well as other medications and supplies that are helpful to include where feasible. Next slide. Next slide. So we wanted to see if ACIP agrees with the proposed contraindications and precautions to vaccination, or if there are any other sections of the clinical considerations that ACIP would like to discuss. Thank you.
So this is open for discussion, and Dr. Cohen, just to be certain, this is not a vote. This is just a verbal agreement with these proposed contraindications and precautions.
Yes, this is for input and discussion, and is not included as part of the vote to approve to recommend use of the Moderna product.
Thank you. Ms. McNally, your hand is up.
I apologize. I'll take that down.
Oh, okay. Dr. Talbot.
Yes, I really like the layout and appreciate it. I think the only thing I find missing is a very brief description of anaphylaxis and the different types of anaphylaxis. I think there's a misconception in the community and in the healthcare field that you must be wheezing for anaphylaxis to be occurring, and that is not the case. So I think there needs to be some description of how anaphylaxis presents so that everyone can recognize it.
Thank you. And yes, we have included in our guidance and fact sheet some of the characteristics of signs and symptoms in people with anaphylaxis to help make that information accessible and understandable to all types of providers.
Thank you very much.
Dr. Stinchfield.
Yes, thank you, Patsy Stinchfield from NABNAB. Just going to ask my earlier question again. Our consideration for repeat doses at the time if there is a malfunction with the needle and some of the doses lost. Did you guys get to discuss that, and what is your advice?
So I think our general advice is, if somebody, if there was some issue with the administration of the vaccine where somebody did not receive a dose, that's kind of an invalid dose. The person didn't receive any vaccine. If somebody received, partial vaccine, or they're, it seems like they got the vaccine, but there are questions, we're not recommending additional dosing at this time. So it's really if there was felt to be, misadministration where no vaccine was received.
Thank you.
Dr. Hunter.
Paul Hunter, a voting member from Wisconsin. I just want to very strongly support this very, very helpful information, and just comment that it's just another example of how much you all at CDC care about patients, people, populations, and converting scientific information into, showing that you care by really making it detailed enough to be usable by us as clinicians and public health practitioners. And I look forward to helping disseminate this information in the community. Thank you very much.
Dr. Freihofer.
Sandra Freihofer, American Medical Association. This is a fabulous presentation and is so helpful to clinicians. So I thank you so much for it. I'm very encouraged that so many people have signed up for VSafe. And, I've seen some media reports that the cyber attacks could somehow make that information not as clear. So I hope that won't happen. I greatly appreciate the comments from the members of the ACIP, particularly the comment that we actually describe what anaphylaxis is so everybody's on the same page. My question is about, and another final comment is about slide number 6. I think it's fabulous that you have listed clearly the ingredients in these two vaccines. And I note in Moderna's presentation, they said that their lipid nanoparticle was made up of 4 different lipids, and one of them was proprietary, and I assume that's SM102. And if you look at the comparison between Moderna and Pfizer on slide 6, Pfizer is very transparent as to the ingredients, and I would really encourage Moderna to do the same. People that have allergic reactions sometimes know what they're allergic to, and I think you don't have to give the amount of what, but if you could give patients a little more information as to what the secret is, so they might get a head start on if they might be allergic. I think that might be important, because I think it's very essential that we figure out what might be triggering these anaphylactic reactions, because that is definitely going to affect effective vaccine implementation.
Thank you, Dr. Freihofer. Dr. Bernstein.
Yes, I want to echo how wonderful.
How you doing? Okay. Need time to take a break?
Don't forget to mute your microphones, please, if you're not answering a question or speaking.
Dr. Romero, I think some people who are doing the public comment are coming onto the phone line. So I'm wondering if we could go ahead and hold, starting at Dr. Bernstein's comment, and take a 5-minute break and let the public commenters join the line and then come back.
Yes, very good. Thank you. So 5-minute break, and then we'll go to public comment, and then we'll continue with the questions. Thank you.